Hello, welcome to Attitudes and Interactions with Older Adults. My name is Dr. Barbara Dantler, and I'm going to give you this little brief presentation to introduce you to the course Care of the Older Adults and the first section. This will be the first of many series, so stay tuned for other recordings. Here you see a bunch of pictures of older adults, and I put these pictures here so that you can look at the many different faces of older adults and aging. No two of them are the same, and they're kind of cute. They're very active. Some are doing yoga, riding bicycles, exercising, playing tennis, having a drink, and just looking all dapper. And so as we enter into this course of study, with the understanding that this cohort is no different than any other in regards to individual qualities of each person. The objectives of this short presentation is to recognize how personal feelings, values, and belief can impact the care provided to an older adult, to articulate the definitions used in regards to nursing care of the older adult, and to describe the settings an older adult may live in. So, when someone says to you the word old, think about how you feel. What are the first things that come to your mind? Do you immediately think of all the bad things, or do you think of happy thoughts of retirement, travel, and grandkids? I myself used to think that old meant death, and so I was very afraid of dying. I think I am a little afraid of dying, but not so much of getting old. I'm starting to enjoy the benefits of getting old. There are quite a few, as long as your health is pretty good. But that only applies to me. I know I've been around many older adults during my life, and they have been always full of life and vitality, a joy to be in. And I've also, as a nurse, taken care of older adults that were sick and their quality of life was very, very low. So I've seen both sides of the coin. So perhaps I need to also reevaluate my perception of aging as time goes by. Do you think about old people being sick all the time? Do you think about them being stubborn? Or how about cognitively impaired? Being older, does it mean that you are going to be cognitively impaired? There's no choice? Does it mean that you are a burden to society and going to cost the economy money? What do you think about when I say the word old? Look at this picture. It's all in how we look at it. It's all in our perception of anything. What do you see when you look closely at this picture? Some of you may immediately see two older people, a man and a woman. They appear to be in an embrace, white-haired and staring into each other's eyes. However, the other side of the coin, and someone else may see two young people sitting next to the fountain, a female with a hat on and a drink in front of her, and a young man playing the guitar and singing. You might even notice in the background a lady observing them as they sit together. So what do you see? It's all in your perception. And we all have our own unique perceptions, and we see many different things. Ageism. Have you been familiar with that term? You will see it again in your e-text if you have not already read that section. But ageism, or age discrimination, is stereotyping and discriminating against individuals or groups because of their age. It is a set of beliefs and attitudes, norms, and values used to justify age-based prejudice, discrimination, and subordination, such as people should not be able to drive after they turn 65 years old. Or when you go to the doctor's office and the physician talks to the younger caregiver as if the older adult doesn't exist. That's a negative attitude toward the older adult. That is a form of ageism. Look at the little picture here that I found. It's a what appears to be a young man on the bus or on a train or somewhere, and he says, "Oh, great, this train is full of old people." That's a form of ageism, a negative attitude against someone because of their age. I'm sure that you have many examples of your own that you can recall. So let's take a closer look. Not so much at the older adult, but at yourself. What are your values, your feelings, and attitudes about growing old and caring for an older patient? Are you afraid of getting old? Do you distaste taking care of an older adult? Take a very close look at your own feelings as we go through some definitions about older adults. These definitions are also in your e-text. However, I wanted to point out a few of them and emphasize the differences. Gerontology is a branch of science that focuses on aging in older adults. It involves the care of the aging person, but it emphasizes the promotion of highest possible quality of life and wellness. It focuses on improving health in our elderly population. It includes also the physical, the mental, emotional, and spiritual well-being of this individual. So gerontology takes a holistic approach. Under this umbrella, you will find the others listed on this list. You will find geriatrics, you will find social gerontology, geropsychology, geropharmacology, financial gerontology, and rehab. What I wanted to point out to you here is that you will often hear the terms gerontology and geriatrics used interchangeably. However, they are different. As I told you, gerontology is a holistic approach, and it is looking at all aspects of the older adult, while geriatrics focuses on the medical care of the aged. It focuses on the care of the sick aged. It emphasizes treatments of pathologies and focuses on diseases and disabilities of the older adult. So it is more narrow and specific, and it falls under gerontology, which is much broader. Please refer to your text for information about your gerontological rehab nurse, which is a specialty area, and the gerontological nurse, which we'll talk about in the next slide. Well, next couple of slides. Here's another word that you should be familiar with and aware that it does exist. Along with ageism, there's always another extreme, and that extreme is gerontophobia. So in the beginning of this presentation, as we started off, I asked you to think about what you thought about aging in itself and what you thought about taking care of an older adult. We all have our preconceived ideas about older adults and about taking care of them. And of course, your ideals have been shaped by your experiences and your attitudes and your surroundings and interactions with older adults in your life. Some of you have had very positive and close relationships with the older adults, such as maybe grandparents or a favorite aunt or uncle or godparents. And depending on that relationship, you could have a positive or negative thought about getting old and or caring for an older person. There's a lot of false information out there about older adults, about nursing an older adult. And first off, I would like to tell you that most of them are absolutely untrue. First off, working with older adults in a nursing home, as we hear, or long-term care facility, is not a dead-end job. Society has forced us to believe that caring for an older adult in long-term care facility as a nurse means that that nurse could not get a position anywhere else. And that is not necessarily true. It's a choice to work in that sector, as it is a choice to work in pediatrics, as it is a choice to work in L&D. It does not mean the nurse could not get a job elsewhere. And if it was because of the economy and hiring, then at some point the nurse would not stay. There are some joys of working with this population, so you should re-examine your perceptions and attitudes toward these older adults. But there are people out there that you need to be aware of that have very, very severe fears of getting old because they equate old with being useless, with being in pain, with being sick, and unable to care for themselves. And that can be quite fearful, especially if a person has watched the decline of a older adult, perhaps with Alzheimer's or some severe chronic illnesses that has left that patient emaciated, devastated, bedbound, with no quality of life. That can be very traumatic for a person, and it can lead to an extreme fear of getting old. So you must be aware of that because you may be in that situation, that you have to understand when a family member withdraws from an older adult, such as a parent or grandparent. And you have to understand that those are some of the views that they're out there that have been shaped by society, that have been shaped by life experiences. Moving on, though, on a more positive note, if you were to be a gerontological nurse specializing in the care of the older adult, you have many roles, such as you have these roles in addition to any other specialty area. You have it in gerontological nursing. And let me back up for a minute because I said specialty area. We have always recognized pediatrics as a specialty area. We have always recognized the nursery as a special area, caring for neonatal care, and we have always recognized L&D as a specialty area. So along the spectrum of life, there are little specialty areas. Why have we not recognized, at least until lately, the area of gerontology as a specialty area, the care of the older adult? Because it is very unique, and there are things that are particularly special to this group that you must be aware of. So it should be a specialty in itself. That's just some food for thought. Well, let's go on and see what this gerontological nurse does. What are her roles? Hands-on care, of course. We're nurses. That's what we do. We give direct care, and we give direct care in a variety of settings. So the nurse should have the knowledge about health care of an older adult. Since we are looking at it as a specialty area, there are things that are normal for an older adult, and there are some things that are abnormal. And that nurse must be aware of those. There also are different disease processes that she needs to understand, and pharmacokinetics, because they don't metabolize medications the way a younger adult would. Rehab and treatments. And the list goes on, with characteristics and treatment options that are unique to the older adult. So it's more than just being able to perform a head-to-toe assessment. All of us know how to do that as nurses. We were drilled over and over in nursing school, undergraduate school, and in our daily practices, we are also doing head-to-toe assessment, new patients being admitted, patient into the emergency room. Although in emergency room, the head-to-toe is more focused, we're doing that. However, there is a different way, unique qualities that you will see in an older adult when you do an assessment that you must be aware of, so that you know what is supposed to be there and what is not. The gerontological nurse is also a teacher, as most nurses are, as you know. We always teach risky behavior and behavior modification. We incorporate health promotion in that. That's no different for an older adult. We still need to teach them about diet and better nutrition. We still need to teach them about cessation of certain habits such as smoking or excessive alcohol drinking. We talk to them about weight and the risk of other diseases because of their weight. So we do this teaching, but we do this teaching in a unique way and how it affects a person who is over 65 or 60. We are managers. Gerontological nurses are managers as well. Someone needs to coordinate all the services and aspects of care for that older adult. And this includes management of an interdisciplinary team. So all the other parts and pieces of the team need to be coordinated and managed so that the care we provide is going to bring this older adult to their optimum level. Without coordination or someone to manage, it will not do that. We're advocates. Gerontological nurses speak up for their older patients. They serve as a voice or assist them to have the voice. They assist them to maintain their independency, their autonomy, especially when it comes to healthcare decisions. And they also help the family directing them to available resources. You'd be surprised how many people do not know what's in the community available to them as far as services, as far as support. And so it is the role of the gerontological nurse to be well informed and aware of all the services and resources that are available. And finally, a researcher. And a researcher can mean two things for a gerontological nurse. One, it means staying current with what's going on, reading, studying, finding the new findings that have come out and adapting them to the care of the older adult. But he or she may also be part of the research, performing it themselves, so that they can contribute to the body of knowledge about gerontology. So the many roles of the gerontological nurse mirror the roles of the nurse in any other practice. It's just specific for older adults. There is old Einstein. And when we think about Einstein, how many of us think about him being old? The first thing that comes to our mind when someone says Einstein is brilliant, IQ off the chart, a little wacky and crazy, we know, had some weird way of thinking about things, like he doesn't need sleep. But in other words, we think of all these other things, but we don't think about him as being old. Okay? So we need, and we have in place, something that helps us determine how we are going to interact with our older adults, this special, unique group. And our interaction is based on core competencies. Okay, core competencies provide a foundation of added knowledge and skills necessary for the nurse to implement in her daily practice as she cares for this group. The American Association of Colleges of Nursing and the John Hartford Institute for Geriatric Nursing published together what is called the Older Adults Recommended Baccalaureate Competencies and Circular Guidelines for Geriatric Nursing Care. And your text has a nice list of all these competencies, and you should really read over them. They're not as difficult as you may think. A lot of them are common sense, I would like to say, nursing knowledge, but they are a guideline, and these core competencies must be met to provide adequate care to the older adult. When we look at continuum of care, we are looking at where this older adult will enter and how they will move through the healthcare system. 48% of the older adults are patients in a hospital. That's on average. 80% of these older adults are receiving home care service on average. And of course, probably 90% of them are residents in long-term care facilities. Because of this, it is most likely that you will encounter an older adult and also be responsible for their care. So don't look at this class as just another notch on your way to your goal. as a nurse, but look at it as a very informative heads up that you will be, if you have not already done so, taking care of an older adult in almost any setting. So where are these older adults that I keep talking about, and why am I so sure that you're going to be taking care of them in any setting? Well, let's first look at where they are. I just told you 40% of the hospital admissions, maybe more, are older adults. This is the entry point for them. People get sick, illnesses are exacerbated. What do? They go to the hospital. This is especially true for older adults. So if you work in a hospital, you're most likely going to encounter an older adult. Acute rehab. And rehab could be in a hospital setting, or it could be in a whole totally separate facility. It's usually done or provided after a person has had an acute event. And the older adults don't have acute events, such as heart attacks and strokes. So if you work in a rehab unit, you are most likely going to encounter an older adult. There are some stipulations about them entering into rehab, and that is they have to be able to tolerate the number of hours, 3, of therapy per day, to be able to stay there or be admitted there to recoup, or to reach back to where they were, or as close to where they were before the incident. In rehab, a very specific plan with specific goals is created, and this is with the patient's input, and the patient must also agree with the goals and the plan. And of course, you know that as nursing, for the goal to be reached, the plan to be successful, their patient must also agree with it. And they are given time frames, of course, and the goal is to work the object is to work toward those goals. You may also see where home health care. I told you earlier that 80% of the patients receiving home health care are the older adults. And there are many programs out there for home care services. Many of them are cared for under Medicare, Medicaid, or a Medicaid waiver program, in which I used to work for, and nonprofit organizations, and private insurance and private pay. It can be most cost efficient, and it promotes speedier recovery since people are in the comfort of their own home. They must involve some type of skilled services for the home care group to remain there, and that's in most cases with a insurance such as Medicare and Medicaid to be involved. So a skilled service, of course, is a nurse coming in and doing something like wound care, dressing changes, medicine regulation, treatments, and so forth. Or they can also have physical therapy at home. They can also have a nursing assistant to come in and help them with their ADLs and some of their IADLs. And so it costs the government probably about 6 times less to have them care for at home than it does to admit them in a long-term care facility. That's why we love to support the caregivers who are remaining in the home with the person as well. Long-term care facility. Now that is something that has had a lot of negative connotations over the years. First, let's begin by saying long-term care facilities are not just for the older adult. Okay. They will take care of any adult that needs this time or is unable to take care of themselves because of illness, disability, or cognitive impairment. We often associate the long-term care facilities as being a place that is unkempt, that people receive bad care, and again, that, the nurse couldn't get a job anywhere else. And we are not, we're exposed to very isolated incidents in the media, in the news, of situations where loved ones have been abused, people have videotaped or put hidden cameras into rooms to catch the abuser. And those cases are isolated. However, they do give most long-term care facilities a bad name. And for my personal experience working in the community and visiting some of these long-term care facilities, can say there are some very, very good ones, and there are some that are not so good. And hopefully, with a voice, things can be changed, that all of them will meet these standards. And they are really, really coming down on nursing homes who are, for a lack of a better word, not meeting the expectations that they've been assigned. But more so, there are some very good facilities that take very good care of the older adults. And so don't have this negative attitude about these places, because they are on individual basis, and you need to go in and you need to see what's going on. But long-term care is for any person of any age, as I told you before. And they can be broken down even more, such as a SNF, which is a skilled nursing facility, or an Alzheimer's care unit. A SNF are for patients whose care is more intensive and they require more skilled services than just being housed in a long-term care facility. Excuse me. The unit is usually found as part of a long-term care facility, or it could also be in a hospital as we go back to the rehab area. And the patients are there, and they may even have intense rehab there as well, but they still have skilled services that need to be done, such as a person who did have a stroke and still on the feeding tubes and IV medications, PICC lines, central lines, those kind of stuff, or someone from a traumatic brain injury or from surgery could be there. The Alzheimer's care unit could be also on a floor designated for Alzheimer's care, or it could be a separate unit on a campus by itself. So it could be, attached to a larger facility. And this area specializes in the unique care required by patients diagnosed with dementia. They may be physically able to move around, but because of their mental decline, they're not safe to be alone. They need 24-hour supervision to maintain their safety. And the goal here is to attempt to preserve as much of the patient's function as possible. So the people that work here specialize and understand dementia and its processes, so they can work day to day with these older adults that have been afflicted with this diagnosis. Other places that we might encounter is hospice. Now, hospice is the care of dying and also the care of the families, the grieving families of the dying person. And it's not just for the older adults, but any age. The goal here is to maintain the best quality of life until they're gone, to support the family and the friends through the grieving process. These are specialized nurses who know the processes and the phases that people go through as they grieve death and dying, or as they have been given the diagnosis or the prognosis that they will not recover from their illness. And so they go through the different stages of grieving almost like a death sentence, which is a very not a good thing to say. It has such a negative connotation to it, but the staff here are very well trained to deal with all aspects of death and dying. The process can last for months, or it can be for a few hours, and so these nurses know exactly what to expect and deal with at any time frame along the dying phases. They can be found in many areas. Sometimes there are a section of a larger hospital unit that may have a hospice section, or there may be a unique facility. And the unique facilities are very soothing and calming. We have one of many here in our area. And this particular one I'm very familiar with because I've had patients there. It sits on the coastline of the lake, Lake Erie, which is one of the 5 Great Lakes. And so the residents there and the family can go out to this courtyard, and there are benches and trees and walkways and and wind chimes, and they can look out and see the water, and they can see the waves, and there's birds and beautiful ducks there. So it's a very calming place to be. The goal is to make sure that they are pain free, or as much pain free as they can be, so they're not worried at this point about addiction to narcotics and so forth. It is more about comfort and preserving that quality of life until the end. Respite care is not so much directed for the care of the older adult, but for the person in the community that cares for them. Respite provides a temporary place for the impaired older adult to reside, allowing the primary caregiver time for themselves. This can be an adult daycare center in which the older adult is picked up by a bus daily, Monday through Friday, or two or less, 1 day a week or 5 days a week, and they are transported to a facility like a center in which they interact with other older adults, and there are different activities that they can do, and things to stimulate the mind and stimulate their ability, while the caregiver gets a break to take care of themselves and other things that may be needed to take care of. In some cases, the older adult can be placed in a long-term care facility, and that is only for a set number of days, because Medicare has a set minimum before you lose your Medicare and it goes over to Medicaid as billing. But they can go there and for an extended period of time, a couple of weeks, so that the caregiver can actually have straight time alone and for themselves, perhaps to take a much needed vacation, or just a time alone straight without worrying about medication delivery, feeding, dressing, and all the other things that may come with an impaired older adult. So respite is something that we really want to see continue to be supported. We have what we call the CCRC, Continuum Care Retirement Community, in which you, of course, would be interacting with an older adult. And this is a concept in which a person can stay at the same campus from independent living on their own to skilled care needs. There are many different setups, and it can be very expensive. Most insurances do not cover it, but it allows this older adult to move and transition through the stages of aging, all under one umbrella. So they have independent living, perhaps small apartments or little condo-like units, and they progress through assisted living and so forth until they need skilled care, or if and ever they need skilled care. Assisted living is not skilled care, but more in between independence and a little assistance. It also can be costly, depending on where you are, what kind of insurance money that you have, and but it helps the person who still has the ability to be somewhat independent to be safe in the community, but have someone to assist them with the things that they are having difficulty with. Perhaps they can do their own personal care, but they need someone to transfer them in and out of the water or wash their back alone. They can eat and feed themselves, but perhaps they need someone to cook the meal. And a lot of these times, assisted living may have a community lunch or community meal place, like a cafeteria, and the older adult has the choice of eating in their apartment or their private room, or going to the common area and eating with the other residents of the area. It could be a standalone community for assisted living, or it could be in a larger long-term facility in which the person has a private room and are able to come and go as they please with the security of knowing there's someone there to help them. They may even have a private cook of their own. There are lots of activities that are provided for them, such as walking and exercise, bingo, they love bingo, and trips. Here in Ohio, the casinos are the big thing, and so the seniors, as we call them, are always planning these bus trips to different casinos, to Niagara Falls or to Seneca, New York, for these trips, and they really enjoy themselves. Foster care or group home. I know when you hear foster care, you think about children being taken away from their parents, or children who have no parents and nowhere else to go. And you think of group homes as someone who is mentally disabled to a point where they need to be in a home where they can be watched, or behavioral issues. And that is also true. But there are foster care or group homes for older adults. These people are pretty much independent and may only need help in one aspect of their activities of daily living or managing the IADLs, and it's a place for them to be safe there, and they live there as a home together. And the person that operates it does not have to be a medically licensed person to operate it. Oftentimes you'll see social workers who decide to open up a group home, foster home for particular groups, and in this case it'll be the older adults. It's a safety net for them as well, but it still keeps them pretty independent, and it keeps them in the community. So now we've gone over the different places that you're going to possibly interact with older adults, and we challenged you about your own personal feelings. So with closing thoughts, ask yourself, has your opinion about getting old or caring for an older adult been affected whatsoever? Maybe you began this course with a positive attitude as already, and it's just reinforced your reason why you have a positive attitude, or maybe it's cause you to do a little brainstorming. Do you think you have what is needed to provide quality care for this age group? I also would like for you to go to the website www.consultgerian.org. Gerian is what it's supposed to kind of squish together there, and look at the information there. There's a lot of information there, resources, readings, some research outcomes, and visit that site and look around and see what is there. There will be more webinars, videos in this series, so stay tuned to your community's board and look for new postings. These will be up 24/7, so they're available for you to review at your own leisure. Have a great day.